Hello, and it's my pleasure to speak at the ZEISS Ophthalmic Virtual Event. My name is Rishi Singh from Cleveland Clinic in Cleveland, Ohio, and I'm going to be speaking on biomarkers and neovascular age-related macular degeneration. And through this talk, we're going to talk about how some of the baseline features and the features we see within the retina over time predict treatment outcomes. We'll talk about the role of OCT and OCT-A as in parameters and fluid markers during the course of treatment. And we'll also discuss how Retina Workplace is my go-to tool for really managing patients with the diagnosis and detection of neovascular AMD, as well as the ongoing management of these patients over time. So one of the things that I want to first point out is how much we've evolved with regards to our imaging modalities the past few years. We now use multimodal imaging for really the evaluation and management of neovascular AMD. And certainly there's a role for each of these. Color fundus photography for at least determining areas of atrophy, as well as teaching the patient. Fluorescein angiography determine leakage if there is truly a membrane that we're concerned about. Fluorescein is our gold standard, as always, for this disease state. Fundus autofluorescence is good for looking for atrophy, as well as kind of ruling out masquerade syndromes like central serous. ICG, obviously, when you consider the condition of polypoidal or feeder vessel lesion treatment. And pretty much for the most part, we rely upon the last two, which is OCT and OCT-A. And I wanted to walk you through where we've learned so much through both OCT and OCT-A about this disease state. Here's an example of a patient, a 61-year-old female with a history of dry AMD and distortion. And you can see clearly on the examination, this patient has a large soft drusen present. And actually, you can look at the OCT map, which is the IR image, and then actually get a drusen area and drusen volume from your current OCT devices through the advanced RPE elevation software that's embedded within each of our ZEISS devices. Now, using this, we can actually look at the quantification of this value over time. And here's two different areas or two different time points for this patient. Here's a close-up view of the macula in this patient. And what you can see essentially is the drusen appear to change in size and morphology. And we can look at the volume change over time, and it has increased, as we expect to see in many patients with intermediate AMD. But one of the things we've begun to learn about this is that drusen can be quite volatile. And here you can see the initial and the 3-month follow-up and even the 6-month follow-up. This patient has good vision at all of these time points, and also differences in drusen size as this patient goes along. And again, my ZEISS RP elevation software is able to then track this change and look at this elevation change. And clearly you can see at the 6-month time point, all the drusen have dissipated. And that could be a sign of impending atrophy, which might be forming. That's been one of the theories behind some of these patients. But it also brings about the question is if you're going to develop a therapy for potentially for intermediate AMD, you must understand the natural history of drusen. And this is a great example of where this software can help us understand better the natural history of drusen changes over time. So drusen are dynamic and really change over time from what we've been able to see. And here's just another example of this patient where you can see clearly that elevation change of drusen have changed as well over time. Here's another example of a patient where you can use the software really to help guide your treatment decisions. This is a 63-year-old female with neovascular AMD in the left eye. She's a fibrovascular pigment epithelial detachment, as you can see, and a little bit of exudation around that as well. And I can then use my RP elevation analysis to look at that large fibrovascular PED. You know, it's always difficult, I find, when we treat patients with anti-VEGF agents and determining treatment response, because these are so elevated and so hard to determine if they are getting really volumetrically better or not. But that's where, again, this RP elevation software comes into play, where I can really look at, again, that distortion of the RPE slab and see what that changes over time. And what you can see after I gave one Lucentis injection here is a baseline area and volume, which is outputted from the machine. And in addition, I can follow that volume change over time, using both on-phos analysis and quantitative analysis in this patient. And after 2 Lucentis injections, you can see an improvement in visual acuity 20/30 with an improvement in the area as well as the volume, which is significant. And again, this is where the software really shines in helping you manage a very complex patient. And here's a patient with a fibrovascular pigment epithelial detachment present and their OCT present at this time point in January when they had their initial conversion to neovascular AMD. Here's all the subsequent time points of the central subfield thickness in this patient after treatment. And the far two circles here are showing you the right two images present here as well. Again, Retina Workplace is an add-on to ZEISS Forum and really has become my go-to software for managing these patients in clinic. Let me show you what the software allows you to do very, very nicely. I can actually map within the software actively this RP elevation. Here I'm going to change it to a different time point in the middle, look at that progression change over time. I can bring up various B scans of interest when I want to look at those. Then I'm going to go to this far right, and I'm actually going to look at the RP elevation within the central 3 millimeters. And what you can see in the green now is where it's actually graphed that RP elevation over time. I can look at quantitative values as well very easily to see what the differences are. And then I can also look at the on-FOSS analysis through the software as well, looking at the RP elevation on the far left and in the middle and the far right, where I can see truly there's been a treatment response in this patient over time. Here's another example of how I use Retina Workplace to monitor the progression of patients with geographic atrophy. This is a patient who is actually involved in a clinical trial for a phase 3 drug for the prevention of growth in GA. And what I've mapped here essentially is the RPE subillumination area, which you can see in the green right here. And this is actually the growth of that RPE subillumination over time. And RPE subillumination, for those of you who aren't familiar with this, is akin to fundus autofluorescence. It's been linearly associated with the growth of geographic atrophy in those patients with this condition, looking at both FAF and SD-OCT subillumination. So it's a nice surrogate if you're not able to do an FAF in every patient. And so using the Cirrus software, again, using ZEISS Retina Workplace, I'm able to map that very easily and look at that over time. And if I want to look, for example, at all of my images that were done on the far right pane, you can see all the OCT and fundus imaging that was performed in a rapid fashion. Here you can see I can look at the thickness analysis here present. And then if I wanted to then dive down deep and look into the on-FOSS analysis, it's as simple as a few clicks of the button where I can then look at the on-FOSS analysis. The quantitative values are shown here. And then I'm going to go and look at the on-FOSS values in just a moment, where it's going to pull up that subillumination change. And in particular, the IR image also can be very helpful looking at geographic atrophy. So I do look at the IR image from the OCT, but you can see the sub-RPE slab present there as well, which can show you the growth of the GA and mapping the GA in this patient over time. So one of the big advances in OCT technology has really been around OCT angiography. And for those of you who aren't familiar with OCT-A, this is a non-dye-based angiography test using OCT technology in patients. And what you're doing essentially is you're looking for movement of red blood cells within vasculature. And the reflectance of this red blood cell through a subtraction algorithm then shows you the actual vessel caliber and density in patients using 12 sequential B scans over time. And what here you can see in that is you can develop lots of B scans. And those B scans then can be segmented to show you both a superficial plexus, a deep plexus of the retinal vasculature, the outer retinal zone, which should have no vasculature at all, and the choriocapillaris, which actually should be very vascularized. And using this on-FOSS visualization can help people really look at various layers of the retina and determine interretinal and outer retinal disease states. Interretinal disease states that I use this for are things like diabetic retinopathy. When a patient with sudden vision loss and diabetes, it's helpful looking at those patients. For outer retinal disease states, I look at things like AMD and CSR when I'm concerned that this patient might have a neovascular complex, which I may have missed with my fluorescein angiography. And one of the most emerging ways of using OCT-A has been looking at this lesion that we call, essentially a subclinical lesion. This is Phil Rosenfeld's work, where he does look at patients with a heavy drusen burden and volume. And what he finds is that while there's no exudation present in the OCT, there clearly on the OCT-A is a neovascular frond that is present in this patient. This is an example of one of the patients within his reporting. And so I think we're learning more about how neovascular complexes form and how we might monitor these sort of patients without exudation over time. And clearly the fluorescein here was not contributory to this. The OCT-A really picked up this patient's sort of outcome. So, what does OCT-A allow for with regards to sensitivity and specificity, especially in neovascular AMD? And this was a nice study done by Jay Duker and colleagues up in Boston, and again repeated by Nadia Waheed in a different fashion. But what they found essentially in this study was that when you looked at OCT detection using fluorescein angiography as a gold standard, it had a pretty good sensitivity and specificity. And if you look at especially type 1 lesions, the sensitivity approached 100%. So the sensitivity was okay, and the specificity was good. But together for type 1 lesions, it's very, very high. But when you add this to OCT alongside OCT-A, and you take two mask graders, for example, the ability to have a detection of a neovascular complex increases greatly amongst these two graders. Actually, it can approach almost 85% increment in these two graders when you combine both OCT and OCT-A. So they're quite complementary with regards to how they can detect lesions. Now, one of the big drawbacks always in OCT-A analysis has been, how do you review these? Because clearly OCT-A is one where you have to look at flow of the lesion, but also you need to look at en face imaging, and you need to be able to scroll to see certain points to see if there's flow through particular areas or changes. And here's actually another real advantage of Retina Workplace, which I've utilized heavily, which is that you can see all of on the right side now, the individual angioplex en face profiles. And in the middle, you're going to see all of those images that are present there. And what I'm going to show you through this quick video, again, is where you can see the superficial, the deep capillary plexus very easily. I'm not having to go into my review software. This is truly embedded within ZEISS Forum. I can look at my avascular level and just the ORCC, which is just above the choroid in this patient. And again, if I see any suspicious areas, I can then dive down and look at the flow of these lesions very easily by clicking on that single B scan on the top right, as you see here. And now I can look at the flow through the lesion and make sure the area I'm concerned about really has flow and would constitute a neovascular complex. Here's another example of a biomarker in OCT, which I think is becoming far more prominent for our audiences and our practitioners, is looking for these elevated U-shaped humps on the OCT. And this can indicate the patient has polypoidal disease. These inverted U-shaped polyps are really indicative of PCV. And for that, treatments have been argued that we should add photodynamic therapy with anti-VEGF versus anti-VEGF alone. There's two specific camps there. I'm in the photodynamic therapy with anti-VEGF camp, where I believe put it together, they're much more effective than using it singularly. We also know that fluid in the OCT is a biomarker for positive and negative prognostication of a patient's response to therapy. In this case, we know that IRF has poor visual acuity outcomes when present in the patient over the period of time of treatment. SRF has actually a positive prognosticator for visual outcome, and sub-RPE fluid really has no impact on visual acuity outcomes, but it can be a negative predictor when combined with IRF and or SRF in patients. And what we also know from many studies is that patients present with SRF most commonly in neovascular AMD, IRF less commonly, and sub-RP fluid the least common in our clinical practices. This was actually data from the CAT study that showed the fluid compartments that are present in each of these disease states. Here's the CAT study, which showed you that negative and prognostication for IRF on the left. Again, those patients who had the presence of IRF at 5 years had a negative outcome, and the patients who had SRF at 5 years had a positive outcome. Now, one of the things I think people forget about this is that patients were being treated here with anti-VEGF therapy, and these were just biomarkers. They were present or absent associated with treatment. The treatment decisions were not guided by this fluid. So I want to be clear about that the outcomes you see here are really because of the guidance, not the guidance of fluid that was driving treatment decisions, but truly a biomarker which showed a negative and positive prognostication in this. And here's a great example of a patient in our practices that we manage with this condition and why retina workplace has become helpful in this. This patient actually had a conversion to neovascular AMD, as you can see, around April of 2020. They received a series of Avastin injections. Each of those red boxes down here shows you the Avastin injection that was given. And then I switched this patient over to Eylea after their central subfield thickness kind of just waned and didn't get much better. There was a slight improvement, at least initially. You can see on the orange, you can see that improvement. And again, after a few of the injections of aflibercept, they really had a nice improvement with this patient. And what I'm going to show you here is first why I do the mapping of these injections, because you can see actually how it actually calculates automatically the number of days between each injection. So I can intelligently treat and extend this patient by the number of days. In addition, I can look at the central subfield thickness improvements, and also I can look to see on the graph different areas or different time points. So here, if I want to show the patient where they started off with a large fibrovascular pigment attachment and hyperreflective material, I can show them that. And then I can also switch over to the on-phos analyses and my quantitative analyses. The on-phos analysis can help me, again, look at that RPE elevation change over this patient's time point. And I'm able to, again, look at those patients' number of injections given. So it can help me to guide the treatment decisions over time. One of the other real beneficial things is the variability in central subfield thickness. And here's an example patient from a clinical study who got a series of injections in the study, and then went every 12 months between injections, and had a nice improvement and stability in their OCT over time. And by that, I mean there wasn't a lot of amplitude of ups and downs during the course of their treatment. And one of the things that the Hawk study found was that when you have patients with high variability in the retinal thickness, the standard deviation is very high, that they have a negative prognostication with regards to visual acuity. And here is the same seen in Kat and Ivan. And we actually did our own study at Cleveland Clinic, which showed the same, which is that with increases in variability, you had massive differences in the final visual outcome in those patients who had the highest quartile of standard deviation of fluid over time in comparison to those patients who did not, by almost 12 letters of vision, so almost 2.5 lines. Now, one of the other sub-analyses that I performed just last year at the Macular Society was I looked actually at the cutoffs of OCT and said, we don't have, AI systems available to us right now to detect fluid and measure fluid. And certainly, measuring some of these parameters can be not that easy to do. But what if we just look at absolute cutoffs and said, if you're below 280, or if you're below 320, or you're below 360, does that impact visual acuity? And is there a difference in the two drugs that were tested in Hawk and Harrier to see a difference here? And I call these controlled and non-controlled CST states. And what you can see here is if you're in a non-controlled CST state of 320 or less, or even 360 or less, you have a very, very good visual acuity gain of almost 8 letters, versus if you're in the bottom phase of this bottom patient cohort, where you had a non-controlled CST state, you had less visual gains over time, almost approaching baseline, as you can see as you go out over time. So really, you can see how the impact can be of the CST state in these patients. And here's a great example of how CST state has been controlled well in a patient. This patient actually converted in January of 2018. You can see the graph here where the initial conversion was. And over time, you can see I'm able to keep their CST state relatively stable with all the injections. I didn't start mapping injections until January 2020, but they were all given injections during this course of time here as well. And here you can see I gave a couple BioView injections and a couple Eylea injections, and I achieved a very, very good low central subfield thickness, albeit still with a PED, as you can see in the far right. But again, allowing me to show again that I have a nice control. And here you can see on the left side, I'm well below the 250 micron parameter. So that really gives me a lot of assurance, especially when managing these patients with neovascular AMD. Let me focus for a moment on my patients with other AMD conditions. And this is where I think, again, OCT-A really shines. This is a patient with central serous in the right eye. 20/50 visual acuity was the change in vision you saw here. She had 4 months of decreased vision. And here you can see on this patient's picture that there's a regular flat RPE area. detachment area with a very thick choroid. So I'm very suspicious, obviously, of the pachychoroid neovasculopathy picture that might be present in some of these patients with evidence of subretinal fluid present. So the real question is it vascularized or not? And what you can see in the fundus autofluorescences truly is there's definitely guttering present here. So there's definitely a component of CSR. On the FAF, you don't see much leakage, maybe a little bit here, which may indicate an occult lesion. It's very hard to tell, though, that there's truly an active lesion present. And the ICG, again, shows you that there is basically no additional leakage on the ICG consistent with a neovascular complex. The question really is this a neovascular complex or not? And here, again, in the angioplex, you can see quite easily that there's flow above Brooks membrane, which is indicative of the CNV. And on the en-face analysis, you can see this large fibrovascular complex. So the conclusion here should be to treat this patient with an anti-VEGF, and the patient then responded nicely. And so this is where OCT-A is critical in the clinical decision making for this patient. And Bailey-Freund put this out, which is sort of shows you again the spectrum between pachychoroidopathy to central serous to pachychoroid neovasculopathy, which is the end stage form of what we showed here, where you get neovascularization present alongside CSR. One of the other big biomarkers here that you can see in patients with neovascular AMD is ORT, or outer retinal tubulation. And here's an example patient with a neovascular complex, which I've treated with multiple anti-VEGF injections. Here you can see the neovascularization complex. Just above it, you see the outer retinal tubulation. And people sometimes confuse this for a cystoid, and they might start to inject this patient over time. But what you can see in this patient is that from August 2019 to almost April, this patient has maintained the same central subfield thickness alongside this ORT picture. So what is, and this is just to show you again their values over time of the CST, which have been really quite stable. I stopped giving injections back in April of 2019, and they've been able to pretty much maintain vision during the course of that entire time period, despite having this ORT present. So what we find from ORT is that it's actually a negative biomarker in neovascular AMD. This is actually from the CAT trial. ORT was actually present in 17% of eyes, and it was a dynamic finding that eyes may resolve the ORT over time. But ORT has worse visual outcomes, as true in the present case, because they're also associated with more macular atrophy. And so that's where this ORT can be helpful to detect, to see if you should inject this patient or just watch the patient over time. This was another study looking at both aflibercept and ranibizumab and compared the two, and really found no difference with ORT development and progression over time. So just to summarize, there are multiple biomarkers at baseline and as treatment commences to predict outcomes in neovascular AMD. ZEISS Retina Workplace and OCT-A are helpful features when evaluating these patients, both at the time of diagnosis and when ongoing management is a necessity. And I can tell you from my standpoint, it's really improved my practice efficiency and my overall ability to care for my patients because of the high-level overviews I get with Retina Workplace. Thank you very much for your attention.